Good morning, good afternoon, and good evening. My name is Fraser Burling. I'm a general physician and rheumatologist, and I work in Auckland, New Zealand at the Rheumatology and Musculoskeletal Clinic in Auckland. My disclosures: I work in a private clinic as the only doctor here, and I'm paid for my services. I have more than 750 EDS and HSD patients at my clinic. I've received no funding from any drug company in relation to the medications mentioned in this presentation. I have received no funding from any external source in the last 12 months. Prolotherapy and sclerosant therapy, what is it? Prolotherapy means proliferation of tissue, which is making more fibers of collagen at a specific location. This happens also when you have a surgical wound and the body lays down fibrous tissue. Prolotherapy therefore just describes an action that is taking place in your body in order to make some new tissues for a ligament or a tendon or other part of the body. So we use a therapeutic action of proliferation. The term sclerosant therapy simply means injecting a substance to form new scar tissue, and it's the same as prolotherapy. It means the same thing. The action of prolotherapy, it's important to understand the action inside the body. The building of new fibers for the soft tissue is the same no matter who is doing the prolotherapy or what agents are used. But the method of getting that process started can be very different from one prolotherapist to another. Some prolotherapists inject multiple areas on one occasion, all over the back, for example, and these people normally use dextrose. Some prolotherapists inject a very tiny, precise area using just one needle at a time, and we belong to the second group, and we'll do up to 4 injections on one day. I aim to reach the part of the ligament that's been torn in an injury, and ligaments almost always tear at where they connect to the bone, which is called the enthesis. So when we use a needle, we aim for the sorest spot in bone contact, which is where the inflammation from the injury is, and we aim to be very precise with our treatments. Substances used for prolotherapy: there are a number of different substances that can be injected. First and foremost, dry needling, which can also happen to a certain degree with acupuncture, uses no substance at all. But when the needle goes through the skin, you get little micro tears and bleeding, and so your blood is in effect your own prolotherapy agent. Saline or salt water can be used by some people. Dextrose is probably the most widespread agent used. Then there are simple soaps like ethanolamine oleate, which used to be available but is not available now. And then there are the stronger agents such as tetradecyl sulfate or polydocanol, which we currently use. There's also platelet-rich plasma called PRP, which uses the patient's platelets from their own blood. This usually starts with taking a person's blood, spinning it down, and extracting the part of plasma, which is the clearer part, sitting just above where all the red cells collect. In my clinic, I trained under Dr. Kenneth Orr, who 60 years ago tried out various options that were available to him. He did not have PRP available. But from the other substances that he trialed, he found that the simple soaps and the sclerosing agents were more effective than other options because they needed fewer treatments and less time to achieve a successful result. At our clinic now, we use the stronger agents such as tetradecyl and polydocanol. We are not set up to do PRP, but as you'll see later in the presentation, it seems to be as effective as the sclerosing agents for prolotherapy for EDS patients. What's the evidence for these things? These agents we use are well established as agents that lay down fibrous tissue. They've been used in varicose veins and hemorrhoids, etc., for more than 7 decades. Prolotherapy has been used in soft tissue for around 60 years, starting with the work of George Hackett, an American orthopedic surgeon. We still have a signed copy of his original text in our clinic. Tetradecyl sulfate was first published as a vein sclerosant in 1946. It may have been around before then, but electronic recording of literature goes back to 1946. There are over 1,200 articles on the use of tetradecyl in both veins and soft tissue already. Polydocanol was first manufactured in 1960 and is also well established as a good sclerosant, and also with over 1,200 articles on its use in veins and soft tissue from 1980 onwards. Many studies have appeared in the last 15 to 20 years on the effectiveness of these stronger agents in soft tissue, including the knee ligaments, the elbow ligaments, The fauces at the back of the throat, which is the curtain that you see at the back of the throat from which the uvula hangs, which is that dongle that you see when you look at the back of your throat. And when you tighten the uvula, it reduces the risk of snoring. The rotator cuff, which is around the shoulder, and the TMJ, which is the jaw joint and other joints and areas. My clinic gave up on dextrose many years ago, even as a backup for those with allergies to the stronger agents due to less effectiveness. It doesn't mean it doesn't work, it just takes a lot more treatment to get there. People with EDS have tissues that seem to be more easily damaged with less force in an accident or sporting injury. However, they still appear to respond well to the strong agents that we use. This is a picture from John Augustus Atkinson in 1803, and it was looking at Napoleon and how he was fighting the Britons and not succeeding. And he noted it's easy to break individual sticks, but hard to break a whole bundle. And on the upper side here to the left upper of the picture, it says, "O diable, all I can do, they'll neither bend nor break." Likewise, it's easy to break a few strands of collagen, but hard to break a whole bundle, even abnormal collagen. And if we build up the bundle of collagen, then breaking the bundle becomes that much harder to do. So, how many injections of the stronger agents does it take to stabilize dislocating joints in an EDS group? To find out, we did a study. This was published in the BMJ group in early 2019. Comparison of tetradecyl sulfate versus polydocanol injections for stabilization of joints that regularly dislocate in an Ehlers-Danlos population. Aim of the study was to find out if there was similarity or difference between the two agents in the number of strengthening injections needed to stabilize a joint from dislocating in patients with Ehlers-Danlos syndrome. Method. This was a retrospective study, so a study looking backwards to past treatments of all patients in a sole practice clinic in New Zealand. To qualify for the study, the patient must have EDS according to the New York criteria, published in 2017. They must have had easily dislocatable joints either at will or on a regular basis. They must have had prolotherapy treatment and been seen again at least 3 months after the last injection to determine that the joints are no longer dislocating. For the purposes of the study, all patients must be over the age of 18. So when we look at the population we had at the time of the study, we had 250 patients with EDS or HSD. This was, however, just looking at those with EDS, whether hypermobile EDS or the classical subtypes. They had dislocated joints at will or on a regular basis. There were 54 from the 250, and had a minimum of 3 months follow-up from the last injection of dislocating a joint. This brought it down to 46. So there were still 8 patients receiving treatment for the dislocating joints at that time of the study cutoff. Injections of tetradecyl sulfate or polydocanol were injected into the ligaments where they attach to the bone on the sides of the joints where they dislocated. We use prilocaine anesthetic to dilute the active agent, as it has a much lower side effect risk than xylocaine, which is also known as lignocaine or lidocaine, depending on which country you're in. So we created a 0.11% solution of tetradecyl sulfate or a 0.25% solution of polydocanol. Patients' joints were considered to be successfully treated if their affected joints no longer dislocated within at least 3 months, but the study went out to 3 years following the treatment. When a patient had more than one joint being treated, the follow-up was a minimum of 3 months after the last joint was treated. Treatments were only performed after fractures, if any, had healed. Injections were not given to a patient if they'd had an active infection, had a mast cell flare, or immediately post any vaccine. And we have a minimum of 2 weeks following vaccine treatments for our usual stand-down timeframe. Dislocated joints were put back in place, i.e. reduced, before any injections were given. Polydocanol was used for any patient with a known sulfur allergy. Injections were given to any one area with a minimum of 2 weeks between injections if the same spot was needing treatment. However, the average was 4 weeks for those that needed more than 1 injection at the same spot. A maximum of 4 injections were given on any one day due to the anesthetic dose. If you give too much anesthetic, there's a risk of the heart going into a funny rhythm. Injections were given in bone contact, which is at the enthesis of the connective tissue sleeve around a joint capsule or surrounding ligament and tendon structures. So when we look at the examples, and I look at the left picture first, this is the joint capsule with the ligaments and tendons that you can see around it. And this is where the tendons and ligaments insert into the bone, and that's where we inject. On the posterior aspect of the shoulder, the same thing, we inject next to the joint capsule. For the hip, looking at the left side first shows the posterior aspect, because that's the area in the hip that's most commonly treated, because people most commonly have the hip dislocate posteriorly. And again, we treat around the iliofemoral ligament at the upper and mid aspects. You have to be very careful going low because you've got a sciatic nerve down low, so we have to dodge that. On the anterior aspect, which is much less common, we use a superior approach, so coming in from above, coming down the side of the iliac bone, because we have the femoral nerve, artery and vein to dodge in this area here. When looking at treating ribs, which can sublux or dislocate, the rib usually pulls backwards, and on here it would pull out to the left side of the screen. You make sure that we've pushed the joint, the rib back in, and then we come down on the rib bone further out where it's close to the surface, close to the surface of the skin, and move along the rib until we reach the space that we're after. When this is over the lung area, we much prefer to use ultrasound in order to avoid missing the rib and hitting the lungs, which sit just below the ribs. Results. So of 250 patients at the time of the study, there were 46 patients who fitted the criteria. 15 of these patients had hypermobile EDS, and 31 fitted within the classical EDS subtypes, according to the New York criteria. There was no difference whether someone had hypermobile EDS or one of the classical subtypes in treatment options or outcomes when we did sub-analysis. There were 37 who had been treated with tetradecyl sulfate and 9 who were treated with polydocanol. The reasons for treating for the difference is that only patients with a known sulfur allergy were treated with polydocanol, and hence the reason for difference or disparity in the numbers treated in each group. Injections were done using body landmarks. These are known as anatomical landmarks, and always in bone contact. Again, some may prefer to use ultrasound if they are not used to using landmarks, and especially use ultrasound when treating rib attachments. All patients had no further dislocations of treated joints unless they had a major new injury, which applied to 2 of the 46 patients. For the tetradecyl group, there were a total of 305 injections around 97 joints, for a mean of 3.1 injections per joint area, a range of 1 to 222, a median of 2. For the polydocanol group, there were 36 injections around 19 joints for a mean of 1.9, a range of 1.8, and 128, and a median of 2. Statistically, the 2 agents were equal to each other, and for those with a statistical bent, here is the data. So the student's unpaired t-test gave a p-value of 0.12, with statistical significance being a p-value of less than 0.05. The difference of means between group 1, tetradecyl, and group 2, polydocanol, is 1.2. Confidence intervals for this difference of the second mean from the first mean is minus 0.34 to plus 2.98. The Wilcoxon rank sum two-tailed test for a non-standard distribution gave a p-value of 0.064 for null hypothesis, i.e. still no difference between the 2 groups. When we look at this graphically, we see a cumulative probability graph for the number of injections needed to stabilize joints. The diamonds are the tetradecyl, which you can see on this line coming here, and the circles are the polydocanol. However, they both track through a same sort of arc, with only a few patients needing more than the average, and 75% of joints needed 3 or less injections to stabilize them. All injections were painful. If it's not tender, it's not in the right spot. There's a bruised feeling that follows for an average of 3 to 5 days, although it can last longer than a week. Usually pain after a week is an adjacent injury not yet treated. Approximately 1 in 100 injections causes a significant bruise. There were no infections or other adverse events in the study. We have observed a 10% crossover risk for patients with a known sulfur allergy to develop a rash from tetradecyl, which is why we use polydocanol in those patients. However, if people have a soap allergy, there's a 10% crossover risk for patients to develop a feeling of being really under the weather for 1 to 2 days. A pain score was not used to measure pain for this study, as these patients had multiple other sources of pain that contribute to their total pain scores. However, we note that the overall level of pain reduces and the patient ends up with little or no pain in the joints that were treated. The quality of life improves as well. Again, other injuries and other factors for EDS, such as mast cell activation syndrome, POTS, which is postural orthostatic tachycardic syndrome, also known as the heart racing and your blood pressure dropping on standing up. Problems with the gut motility, so the gut can become very slow and sluggish. Urine frequency, etc., all contribute to people's quality of life or lack of quality. So measuring a difference that's just specific to the areas treated is really difficult, and so we did not include it in the study. The study was looking at past treatment, so it's a retrospective study, which is a known limitation. It took place in only a single centre. It involved only a single physician, and patients knew what treatment they were having, so it was not a blinded treatment. It relied on patients reporting that they had no more dislocations or were unable to demonstrate dislocation of a joint at will anymore. Follow-up was only from 3 months out to 3 years. However, there's high satisfaction rating from the patients, and we have an overloaded waiting list resulting from these treatments. And subsequent re-injury takes fewer injections to restabilize the joints. We didn't include children under 18 in the study because of the ethics approval processes that would be needed for the study. However, we have successfully treated children as young as 11 at the clinic. A child needs to be able to understand the benefits of a small amount of pain for longer-term pain relief, and they need to have matured enough in their body that we know they're not still growing into their bones and ligaments, which can tighten up the ligaments as they get older. We've had the same success with children as with adults, however. Very recently, we did a 3-year follow-up and this is unpublished data. An analysis this year of the patients in the study group has been performed. All 44 patients who had not had a recurrent in the audit timeframe maintained their joint stability, i.e. none have had a recurrence since, now for a minimum of 3 years out to 6 years. In the audit, 2 patients had a recurrence, and in the 3 years since, one of those 2 has had a further injury causing a subluxation but not dislocation. The other has maintained stability. Help from our allied health professionals is really important. Physiotherapy helps reduce muscle spasm that can cause joints to spontaneously dislocate, and to help with reactivation processes. It's really important when treating a shoulder, for example, to stop the shoulder becoming a frozen shoulder during the healing time. Skin-tight clothing or taping with hypoallergenic tape helps with the awareness of where the arms and legs are in space around you. This is called proprioception, and this is really important during the healing time as well. Massage, if kept gentle, is very helpful. However, people who use their elbows in massage can cause injury, and we don't recommend deep tissue massage. When treating other injuries other than dislocations, some data shows that the use of prolotherapy gives better outcomes at 6 months than steroid injections for treating tennis elbows, for example. Steroids soften ligaments, where prolotherapy lays down more tissue and tightens ligaments up. In EDS, tissue is already abnormally soft, so further softening of the ligaments makes people more prone to injury when they have an accident. For that reason, we've been using prolotherapy for other non-dislocation injuries as well in the EDS population. When treating other sources of pain, we found that prolotherapy is as effective at treating pain so long as all sources of pain are treated. If, for example, when you're treating the tennis elbow, which is the lateral epicondyle, treating that won't treat an injury that's adjacent, such as the annular ligament, which wraps around the head of the radius, or the supinator attachment or pronator attachment, which are muscles that radiate down to the hand. Also, shoulder pain can radiate to the elbow. So if you don't treat all sources of pain, then the pain won't go. You have to treat all sources of pain before the pain goes from the elbow. Just in discussion, early analysis of treatments with strengthening injections from tetradenal sulfate and polydocanol indicates that they're likely equal to each other for efficacy. The study suggests that the process of building up collagen does make it harder to tear down a bundle than the effort required to tear down a few strands, even when dealing with abnormal collagen production. This has not been tested head-to-head against PRP, platelet-rich plasma. However, we have noticed that those who've had PRP injections have not needed prolotherapy at the sites where they had the PRP when they came to this clinic. PRP has been used for those who are allergic to both agents, and we have 2 patients who required that. I also note that an American EDS patients had PRP to a shoulder using the protocols that we published. and has had an excellent result as well. So she went from dislocating her shoulder 10 times a day to being able to throw and catch a ball without any dislocation or pain in the shoulder. She's since had ribs treated and her craniocervical instability treated with dramatic improvement. We now know of others who are getting similar results using the same treatments. So there's potential hope for the EDS community internationally with a non-surgical option for stabilizing joints, with results visible from quite low numbers of treatments needed per dislocated joint. If there's fresh injury, there's no significant reason to not go back and treat the same area. And I always wait a minimum of 6 weeks before treating new injuries to allow nature's healing first. In interpretation, we do need more prospective studies to confirm the results of this retrospective study. And while the treatment of soft tissue injuries with prolotherapy is not new, it's been used in the EDS population for more than 40 years, more importantly, in those with recurrent dislocations that has not been previously studied, we are getting some good results. This study remains consistent with other studies of soft tissue injections with sclerosants. There remain potential that people without EDS who have recurrent dislocations may also benefit from this treatment, and we have seen that at our clinic. PRP, while more expensive in this country, already has early signs of being as effective as these strong agents that we use when patients are treated with the same protocols, although this is still unpublished data. Take-home messages. These treatment options have been tried by more than one doctor now, and similar results have been seen around the world. Whether using tetradecyl sulfate or polydocanol or PRP, the results appear to be similar. These treatments do appear to provide a successful non-surgical treatment option for stopping regularly dislocating joints from continuing to dislocate in the EDS population. I wish you good morning, good afternoon, and good evening, and I look forward to the question and answer session coming up soon. Thank you.